We have to ensure that we are able to deliver the advances to our patients. HER2 mutations are a distinct, rare, but immediately actionable subgroup. Most of these mutations occur in exon 20, but this makes the patients a prime candidate for receiving targeted therapy. So with that brief introduction, I'm going to pass it on to Dr. Stuart Yang to take us through HER2 testing.
All right. Thank you so much for being here, and I know that there's a competing session, and I'm glad that you all made the right choice by choosing this talk. All right, so today we're going to talk about the critical first step, really thinking about how we can optimize HER2 testing in our patients with non-small cell lung cancer. So before we begin, I wanted to do another audience polling question. So here, when you perform molecular testing for patients with newly diagnosed advanced non-small cell lung cancer, and so these are the options below. So number one, after an initial diagnosis of all stage 4 histologies. Number two, after an initial diagnosis of adenocarcinoma. Number three, after initiating first-line treatment for adenocarcinoma. Number four, only at disease progression. And then lastly, number five, I do not perform molecular testing. And hopefully you won't choose number five. All right, great. So here, taking a look at the survey results, 43% of you answered after initial diagnosis of all stage 4 histologies, followed by after initial diagnosis of adenocarcinoma. So really encouraging that the vast majority of you guys are testing for at least at the initial diagnosis of non-small cell lung cancer, majority in adenocarcinoma, but also considering some of the other histologies beyond adenocarcinoma. And we'll talk more about the different histologic subtypes later on in the talk. So before we begin, I wanted to just review sort of the remarkable evolution of diagnostic classification in non-small cell lung cancer, right? So here we start at the comprehensive histologic classification into adenocarcinoma, squamous cell carcinoma, and several others. And so this is really the foundation of how we think about this disease. And then, of course, now we understand that non-small cell lung cancer is driven by different mutually exclusive molecular and genomic subtypes, right? Things like EGFR mutations, ALK fusions, KRAS mutations, and many others. And these are now highly targetable with these newly developed therapies that have been really helpful for our patients. And then, of course, we are starting to understand the different sort of immune subtypes and the immune phenotypes of non-small cell lung cancer. And these are primarily classified by PD-L1 expression. And these are particularly helpful for guiding the use of immunotherapies, which have been transformational for our patients. And then more recently, we are starting to exploit tumor surface antigens as potential therapeutic targets for these emerging class of inhibitors like antibody-drug conjugates and bispecific therapies. And so as you can see here, non-small cell lung cancer is not just like a one diagnosis. It really spans multiple subtypes and really requires a personalized approach. And each of these additional layers of information brings on additional sort of diagnostic insights, new biomarkers, and hopefully opens up avenues for different types of treatment. And so here, this is the list of all the actionable biomarkers in our patients with non-small cell lung cancer in the advanced setting currently. And so here, I've organized them on the left. These are the 10 sort of must-test genomic or molecular biomarkers. And on the right are 3 biomarkers that we should be testing using IHC or immunohistochemistry. And then we also have some biomarkers that are really useful and important for early stage non-small cell lung cancer as well, that are being increasingly used to guide different types of neoadjuvant as well as adjuvant therapies. And so taken together, given this increasing number of targets, we really need to think about doing comprehensive biomarker testing, utilizing a broad multi-gene panel NGS as well as IHC. And so today I wanted to focus on HER2 mutations and HER2 overexpression as actionable targets and as oncogenic drivers in our patients' lung cancer. And so just a quick overview of the underlying biology. HER2 protein is a receptor tyrosine kinase that's encoded by the ERB2 gene in chromosome 17. Now, HER2 and ERB2, these terms can be somewhat sort of used interchangeably to refer to the gene, the protein, as well as the pathway. And so you'll hear this sort of used interchangeably throughout the talk and in clinical practice. And so HER2 is composed of an extracellular domain on the surface. You also have a transmembrane or juxtamembrane domain in the middle, and then the tyrosine kinase domain, or TKD, which is really the main engine of this protein. And so in normal cells, you have a ligand that binds to the HER family receptors. That causes dimerization with HER2, and that would activate downstream signaling pathways that are important for survival and proliferation. Now, in HER2-positive lung cancer, we can have several mechanisms that would lead to hyperactivity and overactivity of HER2. So one, we can have ERB2 mutations, where you have mutations most commonly in the tyrosine kinase domain that turns the gene on, the protein on, and would lead to tumorigenesis. You could also have increased copies of ERB2 genes or ERB2 amplification that can often lead to HER2 overexpression or overabundance of the receptor on the surface that would also lead to overactivation of the HER2 signaling and tumorigenesis as well. And so here there are three biomarkers that we need to think about. These are ERB2 mutations, ERB2 amplification, and HER2 overexpression. And these are the oncogenic biomarkers in lung cancer. And we'll focus and talk about these biomarkers in greater detail. So starting with the activating ERB2 mutations in non-small cell lung cancer. So these are specific mutations in the HER2 gene that actually turn on the gene and the protein constitutively, leading to oncogenesis, right? And so here there are three main subtypes. And the most important here is the tyrosine kinase domain mutations, or TKD mutations, which make up about 80% of all activating mutations. And among this, exon 20 insertion is the most common and the most important mutation to think about. And this is composed of the Y772A775 duplication, also known as the YVMA insertion, which is the most common. But there are also several others that are also activating and within this exon 20 insertion. There's also other mutations in exons 19 and 20 through 23, which is the TKD region. And then we have the non-TKD mutations. So we have the trans or juxtamembrane domain mutations, as well as the extracellular domain mutations, most commonly the S310F mutation, which make up the rest. And so clinically, these mutations occur in about 2 to 4% of patients with non-small cell lung cancer, and they're typically associated with a certain phenotype. So mostly adenocarcinoma, never a light smoking history, as well as an Asian heritage, as well as female sex. But it's important to emphasize here that HER2 mutations can occur in patients outside of these clinical characteristics. So it's really important that we test all patients with adenocarcinoma, large cell, non-small cell NOS, regardless of these clinical features, and actually even consider testing in squamous cell carcinomas in select clinical scenarios. Now that was for ERB2 mutations. Now switching gears to amplification. So de novo ERB2 amplification is a known phenomenon. It occurs in about 2 to 5% of lung cancers, especially when we're thinking about the high level amplification, it's seen at around 1%. And in contrast to the mutations, these are actually associated with male sex and positive smoking exposure. So you can already start to see some differences in the clinical characteristics. And then in addition to being a de novo driver, HER2 amplification can also serve as a bypass mechanism for acquired resistance to different types of targeted therapies like osimertinib, where it can be seen in around 3 to 10% of patients progressing on targeted therapies. And then lastly, thinking about HER2 overexpression in non-small cell lung cancer, here we are using IHC to measure the intensity of membranous staining on the cell surface. And so this is measured from 0, where there's basically no HER2 staining, all the way to 3+, which is the highest level of staining. And so HER2 overexpression of 2 to 3+ is a known poor prognostic factor, can be seen up to 20% of patients, but the 3+, the one with the highest level of expression, is a little bit more rare. It's around 2 to 6%. And in contrast to some of the exon 20 mutations, these actually can coexist with other drivers like EGFR, and the expression actually may change with treatment, and so we can start thinking about how this fits into our diagnostic testing workflow. And then in terms of how these biomarkers are correlated with each other, so most cases with high-level HER2 amplification are actually going to have 3+ HER2 IC, but the reverse is not necessarily true. So not all HER2, 3+ cases are going to have an underlying amplification, and there's no correlation with the mutation. So it's really important to realize that these are distinct biomarkers that need to be tested separately. So why are we talking about HER2 in our patients with lung cancer, right? So Charu and Balazs is going to go into greater detail regarding the clinical and the therapeutic data, but here I just wanted to give a really high-level overview of why HER2 testing is so important and why they're now actionable targets in our patients with non-small cell lung cancer. So starting off with the HER2 mutations, particularly the TKD activating mutations, again, we have 2 TKIs that have been approved in the first and or second line that have been really effective in essentially shunning off the gene. And then we also have, for the rest of the activating mutations, TDXD, which is a HER2 antibody drug conjugate that has been approved for second-line setting. And so activating HER2 mutations are a clinical biomarker that's included in the NCCN guidelines for testing using a broad multi-gene PACE panels. And then for HER2 amplification, currently there's actually no approved therapies specifically for the amplification, but there are actually a lot of ongoing clinical trials. So, this is a really exciting space that I'm looking forward to hearing more about in the near future. And so this is, again, an investigational biomarker, and this can be tested as part of an NGS panel. And then lastly, HER2 overexpression, 3+ in particular. So TDXD, again, was approved in patients with HER2 positive IC3+ solid tumors and a pan-tumor indication, including non-small cell lung cancer patients who have progressed in second-line setting. And so similar to HER2 mutations, this is also a clinical biomarker, but in contrast to the mutations, we have to use IHC to test for these biomarkers. And so now we know that these are really important. How do we think about, actually testing for these mutations and these alterations in the clinic, right? So for the mutations, we can think about PCR-based assays as well as NGS using tissue and/or liquid biopsy. For the amplification, we can think about FISH and/or NGS. And then for HER2 overexpression, again, we have to use IHC. So focusing on both the mutations and the overexpression, because that's what we have the approvals for. So again, for the activating HER2 mutations, there are 2 broad strategies, right? We can use a PCR-based hotspot assay to identify these mutations. And so here, the benefit is that this is fairly rapid, and it requires low DNA input and has quite high sensitivity, clinical analytical sensitivity. But the big drawback is that it doesn't detect all the activating and actionable variants and can actually miss some of the uncommon exon 20 insertions. So depending on the design of the panel, it captures around 75 to 80% of all activating HER2 mutations. Now, in contrast, of course, we have next-generation sequencing, or NGS, which takes a little bit more time, from 1 to 2 weeks. It's a little more expensive, requires a little bit more DNA, but it can detect all hotspot as well as rare activating mutations in HER2, but as well as other actionable targets in non-small cell lung cancer. And so right now, as it stands, this is really the gold standard. So multi-gene testing using NGS is the preferred method for activating HER2 mutation detection. So one important point that I wanted to emphasize here today is that not all the HER2 mutations that we see, that we detect in our report, is actually activating and or actionable. And so just to illustrate this point, here this is a lollipop plot of all the HER2 mutations that were detected on a Gini non-small cell lung cancer cohort, which is essentially a multi-institutional database of all lung cancers that were genotyped using NGS. And here we can see, so each small dot represents a mutation. The higher the plot basically means there's a lot more cases in the mutation. And you can see that the yellow box is the tyrosine kinase domain, and the peak is actually the YVMA mutation. And then when we actually filter all these mutations to only the ones that are activating according to our 3 main subtypes, we actually lose about 50% of them. So about 50% of the mutations are actually not activating, right? And then after that, we have to do a further analysis of classifying whether something is TKD or non-TKD, because that has implications for treatment, right? And so again, on the right in that yellow box, that's the tyrosine kinase domain. And so we have to be able to identify these TKD mutations because, for those mutations, we have approvals for TKIs as well as TDXD. And then that's in contrast to the other non-TKD activating mutations where TDXD is approved. And so just to summarize, right? So for all ERBB2 mutations, we need to answer two questions. So one, is it activating? And then number two, is it TKD? And so this is really my approach of navigating this. This can be quite complex. So the first thing is, is it an exon 20 insertion mutation? Is it the most common insertion YVMA or other sort of duplication or insertion mutation in exon 20? If that's the case, then it's a TKD activating mutation and we can move forward. But if that's not the case, if it's a S310F or Y mutation, this is the second most common mutation, right, after the YVMA. And so this is a known activating, but not a TKD mutation. And then for all the other mutations that don't fit in those categories, I actually check a variant annotation database like OncoKB, but there are many others that are out in sort of available on the internet. I really like OncoKB because it does a really good job in sort of summarizing all the actionability of all the mutations, including ERBB2, and it's free to use. It's has high sort of rigor in terms of the annotation and the curation. It's actually FDA approved for that purpose. And so here, this is an example from the OncoKB showing you all the mutations that's paired with the drugs that are approved and the level of evidence as well as the cancer type for which it was approved for. Now, I can't talk about, give a talk in 2026 without talking about AI. And so one of the, questions that I get from my clinical colleagues is, can we use AI, especially some of these, chatbots and LLMs that are developed more for medical providers to help to detect ERBB2 mutations and to better understand actionability. And so just to kind of go through this clinical exercise here, we're choosing ERBB2 L726F mutation, which to me is unclear. So I'm going to check OncoKB. OncoKB says that it's TKD activating. All right, now I'm going to use a very commonly used LLM called Open Evidence, which I think a lot of us have used in the past. And I asked the question, is this mutation clinically actionable? And if so, what are the FDA-approved treatments for this mutation? And be very concise, because it can be very long. And this is the answer I get. So here it says that this mutation is a missense point mutation that is in the TKD, it's activating and oncogenic according to OncoKB, and that it is clinically actionable. And also provides the different types of therapies as well as which line it was approved for. So it's really helpful, I think, but it's important to see that it actually pulls the data directly from OncoKB. Now, this is another recently sort of developed or chatbot that was released, a ChatGPT for clinicians. I asked the same question, and here we're getting some, sort of a similar result about this mutation. So, just the take-home point here is that I think these AI, tools can be really helpful starting point when we're thinking about these mutations. But I wanted to emphasize to really proceed with caution and really confirm their citations and sources which they provide. And I think it's really these tools are best used together in conjunction with the variant database like OncoKB, of course with the NCCN guidelines and other guidelines that are been provided, as well as your best clinical judgment for these mutations. Now, switching gears a little bit, I wanted to talk about scoring HER2 immunohistochemistry in lung cancer, right? And so again, here we need to use a dedicated IHC assay for screening. And in the clinical trial that led to the approval in lung cancer, they actually used the gastric or G-junction criteria. And so I think a lot of us are familiar with scoring in HER2 in breast cancer, but there are some important differences between the gastric versus the breast. And so the big difference is that incomplete staining counts. So if you have incomplete staining of the tumor cell, it still is counted as a positive. And then there are actually different thresholds for whether it's a biopsy or resection. So for biopsies, you have a little bit of a lower threshold. So those are the two main differences from the breast guidelines. And we really need to be making sure that our pathologists are using the gastric guidelines for lung cancer. And again, HER2 IHC 3+ is the actual biomarker, and right now there's no role for HER2 FISH in 2+ or equivocal cases. So now we talked about the different types of assays. Now let's think about different ways to actually take these assays and create a clinical workflow that we can implement in our clinical practice. So here on the left, I think this is the most common clinical scenario where you have a de novo treatment-naive advanced non-small cell lung cancer patient that comes to your clinic. And so for this patient, I would actually recommend doing NGS, right, to look for the ERBB2 mutations, as well as IHC, obviously to look for PD-L1, but also to look for HER2, as well as CMET if tissue allows.
Now, the second scenario is a scenario that is, very painful to discuss, but actually happens, quite often, about 20 to 30% of cases, where it's a very scanned tissue, and we need to assess for all biomarkers, but unfortunately, it's so scanned that we cannot do tissue NGS. And so here, I would actually, prioritize doing IHC, so PD-L1, HER2, and c-Met as appropriate, and then maybe think about doing PCR that can capture around, up to 80% of activating HER2 mutations. But the important caveat here is that if it's negative or insufficient, we really need to do repeat testing, either with a tissue NGS or liquid biopsy using NGS. And so to talk a little bit more about different strategies for implementing liquid biopsy for patients with advanced non-small cell lung cancer, in particular with HER2, so liquid biopsies can be, really helpful in a lot of clinical scenarios. So especially when tissue biopsies are insufficient for testing, right, as it was the case before, where tissue is not always available for testing. These are referral patients, and the block might be in a different hospital. And really, this enables non-invasive testing, and oftentimes the results come back faster because you're bypassing a lot of the tissue workflows. And so when you get the plasma sample, you do NGS, and if you have mutation detected, that's great. But what if there's no detection of any HER2 mutation or any actionable alterations? And also if HER2-IC is not known. So in these cases, I would actually recommend tissue biopsy. And that's really because the sensitivity of liquid biopsy is really highly sensitive and dependent on the disease load, stage, and ctDNA shedding, even in patients with advanced non-small cell lung cancer. So what that means for us is that negative results cannot be really trusted, and we really need to confirm this on tissue. And of course, we cannot do IHC on liquid biopsy. We need a tissue sample for that. And so the take-home point here is that both tissue and liquid biopsies are really complementary. I think an integrated approach using both, leveraging the advantages of both methods is really the most optimal. Now, I wanted to take you sort of behind the scenes and into the lab to think about different logistical considerations for HER2 biomarker testing and how we can really optimize this process, right? So I think it really starts in the beginning at actually the specimen collection process, where we think about incorporating rapid on-site evaluation or ROSE to ensure that we have adequate material, not only for diagnosis, but also for biomarker testing. And that we as pathologists need to think about biomarker testing in mind and be judicious in our use of some of the diagnostic IHC and prioritize the precious material for biomarker testing. And then, of course, we need to go ahead and perform the biomarker testing itself, ideally in a pathology-initiated reflex testing workflow where we as pathologists do the testing ourselves using a combination of different assays like IHC, PCR, and NGS, as we talked about. And then, importantly, we have to be able to release the report in a timely and an understandable way for our treating physicians. And so, this really needs to be done in a multidisciplinary format, whether in a molecular tumor board, but we need to think about how, the HER2 mutations, whether it's activating or is it TKD, is it a HER2-AM, what kind of, scoring guidelines are we using for our HER2-IHC? And then, of course, this is, easier said than done, right? So there's going to be a lot of different challenges associated with this process. But we can also think about, some different solutions that maybe we can implement to help with this process. And so one thing I think is, I think there still is a general limited awareness regarding HER2 biomarkers in the community. I think we have known about HER2, but it hasn't been as actionable as some of the other drivers like EGFR and ALK. So this is relatively new. So I think we need to continue to raise awareness for HER2 testing through education like we're doing now, through different types of advocacy and outreach in a very multidisciplinary integrated collaboration. And then, as we mentioned before, we have run into this issue of inadequate diagnostic tissue for complete biomarker testing. And I think for this, it would be really nice to consider and implement ROSE, or rapid on-site evaluation, optimize tissue triaging and the tissue stewardship during the actual diagnostic workup of the tissue. And this is an important point for the pathologist. And then also consider doing liquid biopsy, right? Patients with advanced lung cancer, and to look for the mutations. And then there can be oftentimes a lot of different gaps, delays, and inefficiencies in biomarker testing. Someone drops the ball. It's just a big process. And so one solution that I think is really helpful is, again, the pathology-initiated reflex testing protocol, where we as pathologists order testing ourselves for all patients who are eligible. And I think this really helps to expand the testing rates across the board, reduces the bias because we're testing all eligible patients. We're not pre-screening by clinical characteristics. This also helps to minimize turnaround time, and it just really streamlines the diagnostic care and overall. And then there's, of course, still confusion, right, regarding HER2 biomarker testing results. Are we talking about a mutation? Are we talking about protein? What is actionable here? And so I think it's really important that we highlight the distinct nature of ERBB2 mutations from ERBB2 overexpression, right? And then within the mutations, is it activating? Is it not activating? Is it in the TKD or non-TKD? And then in the overexpression, is it 3+ or not 3+ using the gastric guideline? And then the role of different assays that we need to implement for appropriate test selection. And so just to quickly summarize the first part of the talk, so here we're talking about patients with advanced non-small cell lung cancer. And again, we were mentioning these 3 biomarkers, right? Activating ERBB2 mutations, ERBB2 amplification, and HER2 3+ overexpression. And these biomarkers are really important because of the different types of TKAs that have been approved for ERBB2 mutations, for some of the clinical trials that are ongoing for ERBB2 amp, and then of course for 3+, we have second-line ADCs that have been approved. And we really need to be thinking about testing all these patients, right, for these biomarkers. I think ideally at diagnosis, but for the AMP and the HER2 3+, we can think about also testing on progression. And for the mutations, I think it's really important that we emphasize and prioritize NGS on tissue as well as liquid biopsy. For the amplification, we can think about FISH and NGS, and then for the overexpression, of course, we need to think about IHC on the tissue biopsy. So really, we need to start thinking about implementing comprehensive biomarker testing that includes, NGS as well as IHC, right? IHC is making a huge comeback, I think, and it's really critical for our patients with advanced non-small cell lung cancer so that we can assess for all the actionable biomarkers that we talked about today. And again, I think it's really, critical that we are very, judicious about our approach to appropriate assay selection, choosing the right tool and the assay for the right biomarker, and then understanding which result is actionable, and then doing this all through within a multidisciplinary collaboration. And I think this is really critical for advancing care of our patients with metastatic non-small cell lung cancer. All right, so I think that concludes my talk, and I'll hand it over to Balazs.
Well, thank you so much, Stu. That was such a tour de force talk. I think word actually got out, and a lot of people came in hearing, how good your talk is. So thank you for that. My job is to talk about targeting HER2 that you found, through your testing in advanced non-small cell lung cancer. So we'll provide a clinical update on that. And I know that there's some fellows in the room. And in 2002, as I was finishing my fellowship, treatment algorithms are so important today. That was the only treatment algorithm I needed to learn as to how to manage patients with metastatic non-small cell lung cancer. And I feel sorry for you guys today. The right side is your job. And part of that is this precision medicine revolution, whereas we learned from Stu, just in terms of molecular testing, targeted therapies, we have to test for 10 critical molecular subsets. And even within those subsets, there's so much nuance that we need to understand. Just think about EGFR, but it's not EGFR. Is it, the classical alteration? Is it exon 20? Is it an uncommon mutation? So just so much richness of knowledge. And with that new treatment, just think about ALK-positive lung cancer. How many ALK TKIs we have? Generations of agents. Each one is better than the other. And, we have lorlatinib, just learned yesterday that on the CRAN trial, more than half of the patients 7 years into treatment have not progressed yet. So such powerful treatments with new ones, still being developed. So really just an embarrassment of riches in a way, improving, the patient's, treatment continuum, treatment path with metastatic non-small cell lung cancer. But for the 10th subset of patients, HER2-mutated lung cancer, a couple of years ago, the situation was still very, very different. And I brought in this slide because I was actually in the ODAC meeting 4 years ago where poziotinib was being developed, a novel, specific ERBB2 TKI, seemed to have promising activity. And the question was asked to a group of expert oncologists whether it should be approved. At a response rate of 28%. Yes, it did have a toxicity profile. I was so eager to get it approved that I was the only of 2 oncologists on the panel, voting yes. The rest of the panel voted it down, leaving us with nothing outside of standard chemotherapy just 4 years ago for patients with ERBB2 positive non-small cell lung cancer. And I think this negative, feeling is very nicely summarized in this editorial from just a few weeks ago by Dr. Carbone, that ERBB2 used to be, was EGFR's poor sibling, lung cancer's ugly duckling, where we knew that there's mutations that should be actionable. In the laboratory, we could make a difference. But in the clinic, there was nothing that we could do. So let's learn today what happened to lung cancer's ugly duckling. And this is now the treatment algorithm just for this very specific subset of patients that we face today. And just think about sort of, now the rich options that our patients fortunately face, and we'll talk about them one by one to make sure we understand how to nuance, how to sequence. We have now, frontline approvals for zongertinib. We have a newcomer cevabertinib approved for second line and submitted for frontline indication as well. And we have trastuzumab deruxtecan, an ADC, which now has been available for the last 3 years or so for HER2-mutated lung cancer as well. And of course, we have still conventional chemotherapy, plus minus immunotherapy. I think we're still lacking great understanding of the benefit of immunotherapy for some of these patients. So in reality, now we have the luxury of 3 potentially very active lines of treatment that your patient can benefit from, which is of course terrific news, for us, but even more terrific news for the patient, but only if you listen to Stu's talk and you're testing properly and you're finding the right mutations, right alterations that these medicines can target. And these are the ESMO Living Guidelines, kind of summarizing the same information, just of course approvals, come in Europe in different fashion. So let's talk about just the basic mechanisms of action. And before that, we have a polling question. What very specific characteristic underscore the difference in mechanism of action between the HER2 TKIs, cevabertinib and zongertinib? Is it reversibility? Is it selectivity for the TKD of HER2-mutated receptors? Is it their immunogenicity, cytotoxic payload, targeting of extracellular versus intracellular domains? Let's see what you know. So let's see. Okay, so that's a great start. Charu, how do you feel about the choices?
Yeah, and I think this is exactly why we're having this session, right? We want to learn a little bit more about what are the differences between these HER2 TKIs, what is cevabertinib and zongertinib, and you're going to tell us.
Great. So you guys are a wonderful, crew, but you know nothing about these 2 TKIs. So a lot to learn today, because the one, option that you didn't vote for is the correct one. Because the big difference between these 2 TKIs, which are both very selective in terms of efficacy for the TKD domain of ERBB2, but one of them is reversible, one of them is irreversible, one of them targets only ERBB2, while the other targets ERBB2 and EGFR at the same time. So that's the critical difference. There's no cytotoxic payload for either. Of course, these are targeting the TKD domain, and the immunogenicity is not an issue with these TKIs. So let's see if we can improve this percentage by the end of our conversation today. So this is now the summary of the actual mechanism of action. And of course, we have TDXD, trastuzumab deruxtecan, trastuzumab, the drug that we trust so much, for breast cancer, for gastric cancer, activity for ERBB2 positive colorectal cancer. And now we know that we have an agent that we can use, we can trust in lung cancer as well, with an approval for ERBB2 mutated non-small cell lung cancer, but also an approval for, in a tissue agnostic fashion in a way, for IHC high positive solid tumors. So that's TDXD. Then we have zongertinib, and this is now HER2 specific TKI, an irreversible one. And then we have cevabertinib, which is an oral dual kinase inhibitor of both HER2 and EGFR. So in this case, we have 2 TKIs that are quite similar, but they are still different. This is different from the situation of, let's say, tepatinib and capmatinib. Some of the other situations where it's very difficult to make a difference between the TKIs. Here, there's a definite distinction. And again, this summarizes the same. So with zongertinib, you've got both EGFR and HER2, while with cevabertinib, you have the HER2 alteration. I'm sorry, actually, I said it incorrectly. So cevabertinib, the cartoon doesn't highlight it very well, but HER2 and EGFR, while with zongertinib, you have the irreversible inhibition, of course. Now for the ADC, of course, we have very specific elements of the ADC, the targeting moiety, the linker, and the deruxtecan payload, the topoisomerase 1 payload, leading to ultimately cell kill, cytotoxicity. On the other hand, with the tyrosine kinase inhibitors, you have inhibition of the key signaling pathways, the PI3 kinase, and the RAS-RAF MEP kinase pathways, leading to cell death as well. So let's talk about the ADCs in the first place, very specifically starting with trastuzumab deruxtecan. And here you can see the original results from the DESTINY-Lung01 trial. This is a trial that kind of replicated experience from the earlier breast trials, looking at the dose of 6.4 milligram per kg for patients with pretreated HER2-mutated non-small cell lung cancer. And what you can see here is a very impressive overall response rate of 55%. Now you might imagine that for chemotherapy we're talking about 35–40% typical response rate, so impressive on first look, and notable progression-free survival of 8.2 months as well. Activity seemed to be durable, highlighted by the PFS, but ILD was noted to be a significant concern with an incidence of 26%. That's very high, of course. And as a result, this study, while highlighted the activity, but noted the vulnerability of T-DXd here as well, leading to changes in the design of clinical trials going forward, comparing two doses, 5.4 and 6.4. And here you can see that the 5.4 milligram per kg dose showed similar activity, at the same time showed much less in terms of ILD in patients with metastatic non-small cell lung cancer. As you can see on the right-hand side, the response rate is in the 50% range for both. Progression-free survival very similar, durability identical between the two dose levels. As you can see, median PFS, median OS overlaps between the two doses. When we look at the safety, as you can imagine, with the lower dose, we should hopefully experience less significant toxicity, and that is the case here, especially when it comes to drug-related ILD, a very notable, very significant, and potentially truly life-altering toxicity of ADCs in general, T-DXd being no exception. And you can see here that the rate of ILD basically got cut in half by the lower dosage, from 32% to 15% or so. So there is a significant change, ultimately yielding the FDA approval for the lower dose. So this is something very, very important to remember in clinic. And what's also very important to remember is proper monitoring and management of ILD. Here you can see the typical guidelines, where even for grade 1 ILD, which is asymptomatic, just visible on a scan with some new pulmonary findings, you should interrupt, the ADC until you kind of understand, the ILD. Is it truly ILD? Could it be, something else? And only with resolution, should you feel comfortable resuming. But of course, with reoccurrence, this is not something that you could do. And with any higher level of ILD, permanent discontinuation of the ADC will be very important. So this is a critical element for all of the ADCs currently that we use in the management of non-small cell lung cancer. And as we learned from Stu, now we have again, some nice, progress in that area with now 3 ADCs, trastuzumab deruxtecan, Teliso-V, and Dato-DXd available for our patients as well. For each and every one of them, this is important to remember. Of course, with Teliso-V, the bigger vulnerability tends to be neuropathy, though. Now here's the pooled analysis of the DESTINY-Lung01 and Lung02 trial. Again, just highlighting not just the overall activity, but now focusing on a very important element, and that is CNS activity of these agents. We've learned before that T-DXd does have activity for patients with brain metastasis positive breast cancer. So it came as no surprise that yes, indeed, a similar activity to its systemic activity can be noted in lung cancer as well. I don't think we have enough confidence in these drugs yet to not consider radiation, though, for patients with CNS metastasis, but it's nice to recognize that there's still significant activity to protect the CNS compartment. So let's switch our focus now to our newcomers, zongertinib and cevabertinib. So first, let's speak about zongertinib. And this is the first experience from the BEAMI and LUNG-01 trial, phase 1b study design, multiple cohorts. And let's first focus on cohort 1, patients with pretreated non-small cell lung cancer with HER2-TKD mutation. Here you can see that this study showed very substantial activity with a response rate of 71% or so, with the dose of 120 milligrams once a day, with a progression-free survival of 12 months or so, excellent durability, significant clinical activity in this cohort of patients. The safety of the drug is very, very favorable. As you can see when you look at the right-hand side, the grade 3 column, where of course the major concerning side effects occur, that column is almost empty. The major side effect in that category is diarrhea, and it happens very uncommonly. So that's excellent. This is really a very favorable drug as to its toxicity, efficacy, balance. So definitely great to see such a favorable profile. One thing to mention, and I'll come back to it, that due to its irreversible ERBB2 targeting activity, likely there's some cardiac toxicity to remember, though, that requires ongoing monitoring. Dose reductions were very infrequent in this trial, and discontinuation happened only in 2% of patients. And that's, I think, a nice reflection of a very safe molecule in these clinical trials. Now here, again, just some very specific, focus on patients with prior HER2 ADC treatment, where activity was also seen, less, than what I've noted before, just about 48% as highlighted here. Now let's, focus on cevabertinib, as I mentioned, a different molecule in terms of the dual targeting, but reversibility. And this is now the SOHO-1 trial, and we will be focusing on cohorts D and E. These are patients who received 20 milligrams twice a day of cevabertinib, previously treated naive to HER2 targeted therapies, or previously treated with HER2 targeted ADCs. Here you can see, again, excellent activity. If you look at the response rates in the range of 64% for cohort D and 38% for cohort E. Cohort F, we'll come back to in just a couple of minutes. So cohort D, previously treated patients naive to HER2 targeted therapies, overall response rate excellent of 64%. Duration of response is in the 9 months range. Now let me highlight that for zongertinib, those were HER2 TKD mutation positive patients. This actually expanded the entire spectrum of HER2 mutated patients. These survival curves just highlight that excellent duration of response and good progression-free survival in this cohort. Now talking about cohort E, this is now patients who had received ADCs such as trastuzumab deruxtecan, again somewhat of a lesser activity, but still substantial 38% response rate. In those patients, the durability seemed to be quite favorable, 8.5 months. Safety and tolerability, again a very favorable profile. A little bit more in terms of GI toxicity, so that's definitely something that your patient would need to be educated about and require appropriate support. That typically is really just Imodium and potentially dose holds or dose reductions. Outside of that, as you can see, the safety profile is very favorable just as well. In fact, there were no treatment discontinuations as a result of diarrhea, which just shows that as much as it can occur, it's very manageable with a typical management algorithm. In terms of what impacted the outcomes of patients on cevabertinib, as you can see, previous lines of therapy made a significant difference. Patients who had been exposed to less than 2 lines of therapy had a response rate of 75%, truly excellent. Somewhat lesser responses in patients who had received multiple lines of therapy beforehand. Intracranial activity, I think we're still a little bit early to understand this fully, but it's nice to see that for both of the drugs, we're still starting to see evidence that there's significant CNS penetration and CNS activity. Very critical information, as with most actionable mutation positive patients, the risk of CNS metastasis is quite high. So with these two excellent drugs with very, very similar efficacy and really, really favorable toxicity, we as a field, received twins. These are not identical twins. There are some differences, but they're definitely very cute from the perspective that the oncologist can be very confident offering them to your patients, providing a patient with a very, very effective and very well tolerated drug overall. As a result, you might think, we should see, what happens as these twins grow up and maybe, can move into the front line. So that's what we'll cover in the next few minutes. And let's again first focus on zongertinib, and this is now cohort 2, treatment-naive patients with HER2-TKD mutations in this particular case. And here what you can see is a response rate of 76% for this very specific cohort, extremely high. As you can imagine, it's in the range of the osimertinibs of the world in a way. Median progression-free survival also is quite impressive, 14 months or so. Safety profile, just like mentioned previously, very favorable. Grade 3 diarrhea occurs rarely, 3% or so, 2 patients in this particular cohort. Dose reductions needed to be made in 16%, and 7 patients, 9% had to discontinue study drug. Now, of course, there are ongoing studies which I think are fairly predictable, to be honest, as to frontline TKI versus chemotherapy plus immunotherapy, which is viewed as one of the standards of care, and we'll have to see how these studies complete accrual. Now, cevabertinib, let's focus on cohort F. And in this case, again, frontline treatment-naive patients were treated, and as you can see in this particular case, the first report suggested an overall response rate of 71%. Excellent activity just as well. And in terms of toxicity, to my surprise and probably to the field's surprise as well, what seemed to be a little higher GI toxicity in the front line is actually not so bad. The grade 3 events are down to the range of 5% or so, very effectively manageable with loperamide, dose interruptions, delays, and sometimes dose reductions. Otherwise, other side effects, as you can see, are fairly sporadic, and some of them might be related to diarrhea, such as hypokalemia. Again, a randomized study is ongoing of cevabertinib versus standard of care chemotherapy plus pembrolizumab. Results are awaited in the coming years, and again, in my mind, are fairly predictable. TDXD, of course, is tested in the front line as well, and this is the DESTINY-Lung04 trial comparing chemotherapy plus immunotherapy compared to TDXD. I would think this is the study where the results are a little bit less predictable. TDXD, of course, is a very effective drug, but there's a bit more organ toxicity that is a bit of a concern. So I'm personally curious to see how this study will play out. Actually, it might help us determine the proper sequencing when it comes to second and third line treatment choices. Actually, tomorrow, we'll see an update from cohort F, and I'm very happy to report that I actually didn't know that we can show this data, but the response rate for cohort F has gone up. It's up to 75%, as you can see here. And I might also highlight that for this study cohort, no ILD has been seen. Actually, for lung cancer patients, for HER2-mutated lung cancer, no events of ILD have been observed with cevabertinib. So just a bit of safety considerations. Zongertinib, very unique elements which I haven't covered. Of course, diarrhea is our biggest concern, but you cannot forget about hepatotoxicity. It occurs with some frequency, so it's very important to monitor liver function tests. The recommendation is a baseline every 2 weeks during the first 3 months, and then monthly. And there's a very clear guideline as to dose interruptions and dose reductions for grade 3 or 4 ALT or AST elevations. Also, as I mentioned, there's some potential for cardiac dysfunction. The rate is not high, but I think we still need to learn as to how, with long-term exposure, this might play out. As a result, you get an echocardiogram prior to start, have to monitor at regular intervals, and yes, indeed, you have to dose interrupt and discontinue dependent on any development of drop in ejection fraction. Also, ILD pneumonitis, although rare, but has been seen and needs to be monitored over time. And these drugs can, of course, potentially cause fetal harm. For cevolbertinib, diarrhea is the top consideration. As I mentioned, in the frontline setting, seems to be a little bit less of a concern for whatever reason, but still definitely patients need to be appropriately educated, counseled about, and the diarrhea appropriately managed. Hepatotoxicity, similar recommendations that you will need to follow. As much as ILD has not been seen in this particular cohort of patients, but you still need to make sure that you remember. Ocular toxicity is listed in the recommendations as well. And as you can notice, cardiac toxicity monitoring is missing from these special considerations. When it comes to nuancing for your patient as to how to choose which drug, I think some of the differences, different nuancing in terms of toxicity profiles can potentially make a very large difference. So with that, I hope that over the last 25 minutes, I was able to show that now we have 3 drugs and we have twins that have grown up and are moving into a frontline setting, one approved and one has been accepted for potential approval in the coming months. So HER2-mutated lung cancer is not the ugly duckling of thoracic oncology any longer. In fact, it has grown into a beautiful swan with great potential for good outcome of your patients. So please make sure that you test appropriately, following Stu's excellent recommendations, and think about proper sequencing and choices of the great agents that now we have available. Thank you.
Thank you so much, Balazs. That was a fantastic overview. You covered a lot of ground from TDXD to TKIs. And I would welcome questions from our audience. Please feel free to raise your hand, ask us a question. We also have online questions open. We are going to actually go through a few cases for the purposes of adequate discussions and to be mindful of time. I think we might limit our case discussions to maybe 2 or 3 cases, but we'll see how our discussions go. All right, so let's talk about the first case study. And Stu, do you want to walk us through this?
Yeah, sure. So this is a case of a second opinion patient who comes to your clinic for second sort of opinion consultation. And so this is a 60-year-old woman. She has no prior smoking history. She initially presented at an outside hospital with just non-specific symptoms like cough and shoulder pain. And unfortunately, imaging revealed a large 4-centimeter lung mass in the right lower lobe and also a lesion in the scapula. And so they went ahead and actually did a biopsy of the bone, and it confirmed adenocarcinoma, confirmed stage 4. PD-L1 was performed. It was 0%. But unfortunately, the tissue was actually insufficient for NGS as well as other possible molecular studies. And so given this, the outside oncologist, I think appropriately, leaned into liquid biopsy. And so ctDNA testing was sent. And again, unfortunately, no actionable genomic alterations were detected. And so essentially, the patient was treated as a driver-negative patient with platinum pemetrexed and then pembrolizumab. And then unfortunately, after 8 months, follow-up scans showed that the patient was experiencing progression of disease. And so now she presents to your clinic for a second opinion on the next line of treatment. And so here we're thinking about, what is the next best course of option or action for this patient? And so here, let's do an audience polling question. Again, what is the best next course of action for this patient? Number 1, consider second-line standard of care treatment. Number 2, repeat liquid biopsy using ctDNA and using NGS. Or number 3, repeat tissue biopsy in the lung and then perform additional biomarker assessment. Great. So looks like we have the majority of you chose repeat liquid biopsy using ctDNA and also repeat tissue biopsy in the lung, performing additional biomarker assessment. So we'll talk what's the next best step in this clinical scenario. And so here, I think, one of the questions that we can ask is, when should we be using, tissue versus liquid biopsy, right? Because these are two different assays, two different techniques, but, when do we and how do we incorporate both of these testing strategies in the clinic?
And I think, Stu, this is a great point that, this is where stewardship and really talking to your pathologist comes in handy. Comprehensive biomarker testing is no longer just mutational testing, as you pointed out. We have to do IHC testing as well. We currently do IHC testing for HER2 and CMET. But in the future, we may be doing IHC, we may be doing digital pathology testing. So it's really incredibly important now to preserve tissue. And if we don't preserve tissue, we will be in a situation like this, or if there's inadequate tissue, that we have a liquid biopsy, but we actually don't have IHCs. So what we do at our institution is we do both tissue and liquid biopsies, and liquid biopsies can be prioritized in cases of small amounts of tissue or where tissue may be inadequate, so that we can get an answer on the NGS and preserve that small amount of tissue to do IHCs, to potentially use for clinical trial enrollment and other analyses. So I do think that there's a role of doing both, but I'm intrigued by your case here, Stu. So upon initial diagnosis, you said ctDNA was negative. Can you elaborate if there was actually tumor fraction detected or not?
Yeah, so in this particular liquid biopsy assay, it did not assess for tumor fraction, which, as some of you may know, it's an emerging sort of biomarker to look for tumor burden in ctDNA sort of assays. Some of the diagnostic companies do offer it. And so if it's high, tumor burden, that could be used as sort of a signal to say, okay, we are able to assess and have some sort of sensitivity for the detection and be able to maybe put a little bit more trust in a negative result. But I'm curious, do you incorporate that in your clinical practice?
Yeah, so I think this is a very important point. I think if a liquid biopsy comes back with nothing, so if it says nothing detected, we have to be careful to make sure that there is ctDNA shed. And that is where tumor fraction can come in handy. If tumor fraction is greater than 1% or 10%, I'm more confident that actually no detection of an alteration is probably true. I'm more confident in that result. Whereas if the tumor fraction is less than 1%, I tend to think that maybe not enough ctDNA is being shed. So I'm less confident in that liquid biopsy approach. Balazs, your thoughts on this?
Yes, same. I think we need to be very, very careful with what could be uninformative, ctDNA results. So a negative is a negative only if you have high confidence in the statement. And there's been actually nice papers on this, one actually from Foundation Medicine, assessing the tumor fraction, the DNA, guiding that boost of confidence. And yes, indeed, easy to remember 1% being the cutoff, that above 1% that confidence improves. It's, in my mind, I think about it as like an iceberg, Are you seeing the iceberg? How much of the iceberg are you seeing? So the 1% just tells you that now you're starting to see enough of the iceberg to have enough trust in the information. So yes, very important to check.
Yeah, and I think one point that I wanted to highlight is, we're talking about HER2 mutations, so using, I think, ctDNA is really helpful. But for some of the other sort of actionable targets like fusions, we know that DNA-based sequencing is not the best approach. In fact, maybe we can think about using RNA. And so because of the fact that liquid biopsies use ctDNA, we just have to be sort of cognizant of the fact that we're using DNA-based sequencing, and that, we should be considering if it's, if biomarkers are negative, to think about doing RNA sequencing in driver-negative cases. Okay. All right, so here we'll just quickly, again, talk about liquid biopsy testing. Right now, we're really focusing on the clinical sort of genotyping right in the middle. There are emerging sort of technologies that are being used in an investigational setting for screening as well as MRD. And then again, right now, the current clinical indication for patients with advanced non-small cell lung cancer is really for genotyping patients. So it's after pathologic diagnosis, prior to systemic therapy. And this is really helpful when tissue is insufficient, and also for progression on targeted therapies, so for resistance clone. And so the take-home point here is that, especially if your assay doesn't have tumor fraction, if the plasma is positive for an expected pathogenic alteration, this is very specific, and it's most likely real, and it can be acted upon, and doesn't really need a tissue confirmation. However, if the plasma is negative, this could actually be due to low sensitivity, and I think it's prudent to actually consider retesting on the tissue. And here, this is a framework that the ISSC has proposed in thinking about how we can use both tissue and liquid biopsy in a highly complementary approach, which I think is the most optimal way of doing so. All right, so for our patient, so she actually went ahead, we actually proceeded with a repeat tissue biopsy because we didn't have the tumor fraction information, so we weren't sure if this was because of low ctDNA shed or if this was a true negative. And so during the tissue biopsy, during the procedures, the cytopathologist was actually present in the operating suite and to assess for adequacy of biomarker testing through rapid on-site evaluation, which is really helpful to get that adequate material. And then in the lab, when the specimen came in, the pathologist was understanding that we really need to prioritize biomarker testing here. So we did c-Met-IHC, HER2-IHC, as well as NGS on this sample. And so everything was sent up, and then now the results have come back. So here on the NGS, we have ERBB2 L768S. We also have CDKN2A and MTAP homozygous deletions. HER2 was 1+ by IHC, and then c-Met was also 3+ in 10% of tumor cells. So now let's kind of break apart and take this and try to have a better understanding of what these results all mean. And so before we do that, let's ask what are some of the practical guidance for the clinicians on how to actually interpret the molecular report. I'm curious to get both of your thoughts on this.
Yeah, I usually phone a friend. If I'm having issues, I would call Stuart or my colleague at Penn. But I think it's becoming increasingly complicated. ERBB2 exon 20 insertion mutation should firstly not be confused with EGFR exon 20 insertion mutations. I think first and foremost, let's think about these as separate. They are separate. Now we have targeted therapies. Overexpression is something where we can come in with an ADC. Mutation is also where we can come in with an ADC, but overexpression is not applicable for a TKI. But I think what's most challenging is the activating versus non-activating mutations. Are they in the tyrosine kinase domain versus not? And I think, Stuart, you showed us a very nice cheat sheet or cheat resource in OncoKB to be able to access.
Yeah, I may just comment for ERBB2 very specifically. When you look at the mutations, I think the common one that we can remember is YVMA. So if you see that in the report, you can have a high level of confidence that that's a very actionable as the most common. So in that case, I don't think I need to ask anyone. But outside of that, yes, indeed, the other mutations are so rare that you always need to just double check a little bit before committing a patient to potentially multiple sequences of treatment. You certainly don't want to make that incorrect decision. And this is where, yes, indeed, we have friends, fortunately, at least hopefully some of us. But on top of that, yes, I think AI has helped a lot. And somebody who's like running our thoracic tumor board, I started to use AI in the middle of tumor board to just improve our conversation when there's an uncertain situation, uncommon situation, to bring in quickly some starting points of discussion, literature, and I find them helpful, for such situations. But yes, indeed, AI is not always correct. It gives you material, but you need to confirm the correctness of that material before you commit to it. So a little bit complicated for us as clinicians, but great for patients on the other end. So we have to do the extra legwork.
Yeah, for sure. And so, this is an example of that case where this ERBB2 mutation, to me, it's not 100% clear whether this is number one activating or if it's in the TKD. And so here, we're going to have to lean into some of these resources that I talked about to investigate further. And we'll do that later. And then now we have CDKN2A and then MTAP. These are co-alterations. And, of course, with the MTAP, this is an emerging target for clinical trials that I think is really exciting. And then for HER2, 1+, again, 3+ is the actionable, and this is 1+, so not really actionable currently. And then c-Met, the actionable, the criteria is actually 50% with 3+. So again, this is not actionable as well. And so, looking at this ERBB2 mutation, we can see that this is not an exon 20 insertion. So we check now, is it S310F? That's not the case. So now we're going to look at OncoKB. And so in looking at the OncoKB here, it says, I type in this exact mutation into the portal. Everyone can use this, patients, clinicians, And what we see here is that it does tell us an answer that this is a TKD activating mutation that is likely oncogenic, also provides the different therapeutic indications as well in the drugs. And so, given this information, I think we have pretty high confidence that this is, activating and actionable with the TKIs as well as T-DXd. And so the patient is a candidate for these really effective therapies. And then now, the patient will have a discussion with the clinical team on the next line of therapy based on the different toxicity profiles and the preferences that you all discussed. All right, so moving on to the next case study.
So let's talk about some case-based decisions for the oncologist. And this is from my own practice. A patient actually I met first time in our hospital's emergency room, which is really never a good place to have a first encounter with a patient, to be honest, especially if it's a New York City emergency room. But that's just how the situation happened. So this is a lovely, lovely person who came into the emergency room with just some new back pains that just never went away, and suddenly some chest discomfort. And in the emergency room, thinking that she had some cardiac issue or something, they did some scans, and the scans identified both, what you can see on the right side, that PET positive lung finding, later PET CT, and also, what seemed to be high concern for bone metastasis of, likely a primary lung cancer metastasizing to the bone in both the thoracic spine as well as the sacrum, as you can see. From that on, she had, workup, including a brain MRI that was negative, was discharged, from a short stay, and was followed up, in the outpatient clinic. Turned out that as she was, being, evaluated, developed COVID after, being in the emergency room. So actually her biopsy had to be delayed. And I brought her in just for a ctDNA test to try to expedite the completion of her molecular testing, because she was a never smoker, and our feeling was that there was a very high chance of a molecular actionable alteration. Here you can see some more of the imaging findings, with the destructive thoracic spine lesion, as well as the right-sided lung lesion that seemed to be the site of the primary. So ctDNA was sent, and a couple of days later it came back. Maybe I can ask too, do you want to look at this ctDNA report? Is it informative?
Yeah, I think this one is a very classic sort of, YVMA, the most common exon 20 insertion mutation. So, it all fits sort of with the clinical history. We have the right mutation for the right patient. And so, yeah, I think this helps to confirm that.
Yeah, so this was one of those awkward situations that I had a molecular finding in my hand. We have these great drugs that we have available, but I did not have a pathology report.
Would you want to wait for pathology? You already have an actionable mutation.
Would you feel that we're in the age that we do not have, Stu is sitting right in between us. We no longer need a pathologist?
I think in this situation, you have a diagnosis based on radiographic appearance. We think this is lung cancer in the pattern of spread as well. And then if we find a targetable alteration, I think we can initiate targeted therapy.
Yeah, great thought. And I have to say that I think we're close. I've never felt fully comfortable yet in the frontline setting. I still feel that for many, many different reasons, Stu needs still that job, to be held. But I think guidelines maybe at one point will be developed under what circumstances we can accept a molecular test result. In reality, our liver cancer colleagues, treat patients with just, imaging findings. In the past, they've treated patients with just AFP, levels, that patients, reached. So I'm sure one day we'll have that. I didn't feel that we were ready. It took a while to get ultimately a bone biopsy and a report on that. But in the meantime, at least this finding allowed me to educate the patient that we believe that this is the disease she has, discuss the options. The options included actually participating in a clinical trial, and the patient was very eager and anxious to participate. So 3 weeks later, ultimately we had a pathology report, as you can see here, confirming that lung adenocarcinoma, allowing a treatment start. So, how would you treat this patient? First of all, she has that, back lesion. Do we urgently initiate treatment in the meantime with radiation, chemotherapy, or are we anxious enough, for the clinical trial to wait for it?
We should preface, right, Balazs, when you saw this patient, targeted therapy was not yet available.
It was not yet approved, no. Let's see. Okay, well, we've got a spread of responses, and I think that's not inappropriate. I have to say, palliative radiation is always a reasonable discussion in a patient with a spine met. It turned out that the patient, by the time she left the ED, the pain actually sort of went away and felt comfortable waiting. Urgent start of chemotherapy is also not inappropriate until you wait, molecular test result. What's inappropriate is to give immunotherapy at the same time, because as we learned, if you expose a patient to immunotherapy but then need to switch because of a molecular finding to a better agent, such as an EGFR targeting drug, there could be significant toxicity with that particular sequence. So you should never give immunotherapy to a patient with metastatic lung cancer unless you have completed molecular testing. Now, the urgency of chemotherapy, is very context dependent. I don't know, do you see that patient frequently where you feel that you need to give a cycle of chemo?
I do not, actually, and I think we hypothetically talk about it much more than we see it in practicality. Usually there are other maneuvers that we can come in with to relieve pain, palliative radiation therapy, steroids, pain medications, and I think it's a constant education of the patient to say, we want to make sure that we get the treatment right, and are there other things that we can do in the meantime?
Yeah, I agree. I haven't seen that patient for a while. And I must say that ctDNA helps reduce that number of patients, because nowadays with ctDNA, in max 7 days, if a patient is so sick that they need urgent treatment, typically the ctDNA is informative. So the minimum you want to wait until your ctDNA is back, and hopefully with that you can make a more informed treatment start as opposed to just generic chemotherapy. So yes, indeed, the clinical trial seemed to be a good decision. Again, radiation was deferred. The patient actually went on this clinical trial and was randomized not to, what we were hopeful for, not to TKI, but chemotherapy and immunotherapy, and actually tolerated it very well, had a nice initial, stability, some improvement on the trial, and of course received some bone targeting therapy at the same time. But 8 months into treatment, she had, again, some vague pains, chest roll, lower abdominal, pelvic pains. Strangely, I did a CAT scan of her torso, and that showed completely stable disease, somewhat fooling us. And that's when we decided, as the pain was just quite notable, to actually get a PET-CT in addition to the CT. And the PET-CT suddenly showed a number of very active bony metastases correlating now with the pain that the patient was experiencing. Actually, again, a really smart and eager patient. She decided to participate in a short trial of radiation in a clinical trial and benefited from it, and then was able to initiate single-agent HER2 TKI therapy, which at that time was already approved. And what you can see here is the miracle of precision medicine. On the upper panel, you see the pre-TKI PET scan, and on the lower panel, you see the patient's PET scan a few weeks after starting the TKI. It's lights on, lights off. Just a complete metabolic imaging response to a little oral option with very limited side effects. It's just a miracle, of precision medicine. And this is exactly where testing is so important. Could you afford not diagnosing a patient where you have such an incredible treatment option available? So making sure that the molecular testing is done correctly, comprehensively for each and every one of your patients is just so important.
This just highlights that it's so important to know about the mutational profile. So even at the time when you initially met the patient, HER2 targeted therapies were not available. But if this patient had presented to us today, I want to ask you, Balazs, which drug would you choose, and how would you think about sequencing HER2 targeted therapies?
Well, I think number one, and there's no question, I think, on my mind, and I think on most of our minds, that the TKIs are so effective and so well tolerated that they are obviously the frontline standard of care. Now, how to sequence past the TKI, I think, is going to be a more challenging question. Can we sequence one over the other, one after the other? We're not sure. And I think understanding if there's some potential non-overlap in terms of resistance will be important. Until then, I think I'd much rather just go with the TKI and then TDXD versus chemo sequence. Maybe slightly favoring TDXD, but I must admit, there I don't have a very strong favorite. I would just work very hard that my patient, would be able to get all three, treatment blocks over time. So keeping, safety in mind is very important because that preserves your patient's ability to potentially benefit from the next line of treatment. Now, a more challenging question is, between the two TKIs, which one to choose? And I think, in a way, zongertinib coming first and having such a favorable, profile looks like, that's a good choice, and there's definitely no question about it. But I think in medicine, it's always nice to have multiple options, and I think as we're just learning about the slightly different mechanism of action, the lack of, for example, the cardiac issues, there's definitely a fair number of patients where I think, that you could make as good a decision going with cevabertinib, for example, a patient with some underlying cardiac disease or some pulmonary issues, for example. I don't know how you're choosing in your practice.
Yeah, I think one thing is very clear that we don't know how to sequence these optimally. I think in the data that you shared in BEAMIAN as well as in the SOHO studies, there did enroll both treatment-naive cohorts, but also patients who had been previously exposed to ADCs. So we may have more data of going from ADC to TKI than from going to TKI to ADC. But I agree with you. I think coming in with an oral therapy is very meaningful to patients. It's going to be about modulating side effects. I think we're going to be introducing ADCs as well into the whole treatment plan. Now, where that comes in, I think we'll learn more in the future. I think in the interest of time, perhaps we'll skip this case study.
Okay.
I'm going to move ahead because we do have another section here. These slides will be available, and we would welcome all of our attendees to look through these cases. We put a lot of time and effort in them, but we must keep the discussion going. I think we talked a little bit about ADCs versus TKIs. I want to just focus a little bit in the last 5 minutes or so managing patients on these HER2-directed therapies. Let's start with ADCs. Balazs, what are the key toxicities that you look for? ILD, how do you think about that when you're...
Well, ILD is the big one, the biggest one, although there's a range of toxicities, but that's the largest concern over time for the management of your patients. I think we've learned the rules from our best colleagues in terms of making sure that you appropriately screen for it, that you appropriately monitor for it and very quickly intervene. So we follow that sequence. So of course, making sure that your patient would seem to be a good candidate for it, doesn't have significant underlying ILD to begin with. Early monitoring, maybe not 3 months, but 6 weeks of the first CAT scan. And from there on, patients, of course, need to be well educated, well counseled, reporting symptoms between visits. And as soon as there's any particular symptom, very quickly evaluate, discuss with your pulmonary colleagues and intervene. Typically, of course, with stopping the medicine and introducing, steroids, very quickly. So very, very, very important to, follow those guidelines. Fortunately, they have been well established, easily available. There's no particular reason, to go around them in any particular way. Just make sure that you follow that very, very steady routine, without a glitch. So that's a critical element.
And I think I would just like to highlight for our audience that managing pneumonitis with ADCs is different as compared to managing pneumonitis with immunotherapy. Grade 2 ILD or pneumonitis with an ADC calls for permanent discontinuation of the ADC. If there's grade 2 pneumonitis with immunotherapy in a robust patient, I have actually re-challenged patients only with grade 2, not with grade 3. But I think with ADCs, it's a completely different ballgame. We should never attempt to re-challenge. Other toxicities with TKIs, I think diarrhea seems to be one of the top toxicities across both drugs. Maybe one has more, maybe the other one doesn't have as much in the frontline setting. How are these discussions, Balazs, when you're talking to patients? Are you giving them prophylactic Imodium or having them come in more often to your clinics?
I don't think coming more frequently to my clinic helps managing diarrhea.
Managing, keeping an eye on them, managing their labs, I don't know.
I'm sorry. The bathroom at home works just fine. But kidding aside, it's education up front so that they anticipate it and they have tools to manage it. So early on, making sure that they start using Imodium, but also report, assessing the frequency, the severity, making adjustments as needed. And we've learned this now for 20 plus years. This is nothing unique. This is something that happened to so many TKIs. All of our oncologists around the globe are very comfortable managing this type of gastrointestinal toxicity. So you certainly shouldn't be fearful of it. But appropriate discussions, counseling of patients is very important. And of course, if it's a significant degree, or even if it's a lesser degree, but not how should I say, impactful for a patient's quality of life, we have other management options such as dose interruptions and dose reductions as well. With those, definitely your patient should be able to stay on the drug with the GI toxicity well managed and hopefully long-term benefit in terms of treatment efficacy.
All right. Bridging the divide from identifying gaps. We talked about rebiopsying situations. What are some key challenges and best practices for effective MDT collaboration across different settings? Do you think we should have access to multidisciplinary tumor boards, or maybe should there be precision medicine tumor boards for these patients? Stuart, we can start with you.
I think this is really an important question. I'm a big sort of believer in the multidisciplinary framework. I think a lot of us sort of practice in that setting where we have a group of thoracic pathologists, thoracic surgeons, thoracic medical oncologists, thoracic radonc, all sort of coming together and being able to collaborate and discuss a lot of these difficult cases, but also to build some clinical workflows. But I also understand that this is not the reality or some of the clinical practice that's out in the community. And so for that, I think it's important to have a system in place where you are able to reach out to your sort of thoracic experts or specialists who have an interest in that area. Again, leaning into AI, some of these tools, understanding the limitations and the need to confirm and check. But I think it's a good starting place to sort of get like a curbside consult with some of these LLMs that are available for physicians.
Any thoughts on streamlining care pathways for HER2 mutant lung cancer? I know we talked about doing complementary testing with liquid and tissue to identify these patients. But what else can we do? What strategies and tools maybe have to really take care of these patients across the continuum? Balazs, your thoughts?
Well, I think the biggest issue for them is to make sure that we identify them. I think that's where the streamlining molecular testing in the most efficient, comprehensive ways is the critical element. From there on, when you have recognized the patient with HER2-mutated lung cancer, I think right now some of the treatment choices are actually fairly straightforward. The AE management is not complicated. Patient education is fairly obvious in terms of how to do it. Of course, there's still some nuancing. We spoke about, for example, the cardiac monitoring that you need to do for zongertinib, the hepatotoxicity monitoring that you do not want to forget for both of the drugs. So those are critical, kind of foundations of keeping your patient super safe. But I think we all can feel, fairly encouraged that with these TKIs we have not just highly effective, but really favorable choices for our patients toxicity-wise, being able to help them maintain a very high quality of life while getting their cancer under control.
All great points. All right, we are in the final minute and would love to see if there are questions from the audience. Are all of you, maybe we'll do a show of hands, are you routinely testing for HER2 in the advanced metastatic non-small cell lung cancer setting? And I mean HER2 mutations first. You can show hands, okay? We have 1, 2. Okay, so not routinely. Have you incorporated immunohistochemistry into your pathways? Depends on pathologist, you have the discussions, and really varies depending on the situation. Great. Any other thoughts from the audience? All right, well, this has been a fantastic event. Thank you, Dr. Yang and Hormuz, for your expert didactic presentations as well as the case presentations. Here is the QR code to earn credit. You can click on the earn credit icon or scan the QR code, which will be valid through the end of June, June 27, 2026. With that, thank you for staying with us through the end of this event, and I hope you found this program educational and informative. Have a good night.